We spend so much time as program integrity professionals thinking about, well, how could we better identify and prevent and detect fraud, waste, and abuse? But, I often wondered, what do the providers think about it? Much like beneficiaries, the great majority of them are participating in the program the way it's designed to be and believe in the mission of Medicaid and what it's designed to do. So why not ask them? What do they think about this from their perspective? Where's the risk? What are some creative ways we could think about solving program fraud, waste, and abuse challenges with a little insight from providers? I was curious, so I thought maybe you guys would be too. So I hope you find some value in this session. For us at Pondera, this is what we're about. It's analytics with context. It's providing that creative, innovative way to think about what we can do with really, really powerful technology, but putting the analytics with some context. And what I mean by context is humans. You can't do this with a machine alone. You really need that component of what we do and to maximize its effectiveness. Some of you may remember prior sessions with Pondera. We often pair with costume. And that's really more so to catch your attention because we think we have a message that's interesting, that's valuable to share. So I am not a doctor. And in fact, several people asked me if this thing worked, and I said I didn't know. I really don't. So that's not my background. My background was sitting in these chairs with you folks. If you don't know, prior to coming to Pondera, I did serve as the Program Integrity Director for the Department of Children and Family Services in Florida, so on the front side of the process, looking at program integrity risks with eligibility. And then prior to that, I served in the Medicaid Fraud Control Unit and other government agencies before that. So entire career has been seeing things from your perspective. Being in the private sector, I actually learned a few things where I thought things were a certain way, being on the government side. So it's been nice to have a different perspective on things, and it's frankly really nice to work with so many different clients and see different states and creative ways that they're solving problems. It's given me a broader perspective on what we do. And so, I don't have any felons here this year. Sorry, there's no felons. These are the good guys, everybody. So be nice to them. I won't belabor this point too much. But there was a few folks that I reached out to, perhaps to participate in the session, who just didn't want to be in that position, right? So to be up there talking about this, it's almost a little bit taboo, right? For writers to come out and talk about fraud within their profession. So be nice to my speakers since they were willing to do that, because I do think they believe in the program and its mission and want to help us to be more effective. With that being said, let's just talk about what we're going to do. So introductions. We're going there in just a second. I've given you pretty much the session background. We'll have a discussion. So we've got some prepared panelist questions, some areas that we thought might be of interest for you to hear about. But I did reserve a block of time for your questions. So as our speakers are talking, if they're hitting on an idea or an area you want to dive into further, please ask questions. And they know to expect that, and they're excited to hear from you. Okay. All right, so let me tell you a little about the folks who were willing. By the way, these guys on their free time are here. So I think that's important. They have careers, patients, practices that they've left to come here and be with you guys today on their own time. So I really appreciate that. So at the end is Richard Knight. He's a pediatric dental specialist and a diplomat of the American Board of Pediatric Dentistry. He graduated from dental school at the University of California, San Francisco in 2002 and received the Robert W. Rule Award and was inducted into Omicron Kappa Upsilon Delta Honor Society. That's a mouthful. Realizing that his true calling was working with children, he then completed a 3-year residency in pediatric dentistry and received a master's degree in oral facial sciences. He currently lives with his wife and 3 children near Sacramento, California, where he masters his skills in dentistry for children and individuals with special healthcare needs. So welcome, Richard Knight. Next, we have Dr. Michelle Trick, and she is an advanced RN practitioner at Baptist Children's Hospital. She is an ARNP and holds a doctorate in nursing practice. She has 25 years of hospital nursing experience in pediatric acute care, emergency room, and oncology. She lives and works in the Miami area, where she is a patient care supervisor in the emergency department and chair of the Quality and Medication Safety Committee at Baptist Children's Hospital. In addition, she implements evidence-based practice into patient care, as well as volunteers with pediatric providers for various medical missions. So, welcome, Dr. Tripp. All right, and next we have Mr. Dwight Osteen, who is a regional administrator for Creekside Center for Rehabilitation and Healing. He has 23 years of experience in post-acute rehabilitation. His roles have included Regional Director of Operations, Administrator, and Healthcare Consultant. He is currently a Senior Regional Administrator for Care Right Centers in Nashville, Tennessee, where he leverages his strong working knowledge of clinical systems, regulatory billing compliance, and process improvement strategies to ensure quality care and operational stability. Mr. Osteen. All right. So a couple of topics of conversation that we're going to head on today. Improper billing, fraud risk in both fee-for-service and managed healthcare systems, incentives and pressure to generate improper payments, beneficiary-driven fraud, relationship risk, kickbacks, and network schemes. These are just some of the areas where I thought the provider perspective would be really interesting. All right. All right, first up, panelist. All right, so the first question is, in your experience, what are some of the most susceptible areas for fraud risk in government benefit programs like Medicaid and Medicare? We'll stay stab at that.
Sure, I'll start.
You got it.
Well, again, Dwight Osteen, and the skilled nursing sector, a lot of our billing processes are centered around an MDS instrument or MDS assessment tool. This particular tool is quite sophisticated, and there's a lot of moving parts to it, but there are certainly some trends that can be analyzed and picked up on in terms of billing. Tennessee recently went to a case mix scenario in a 48 drug grouper type billing strategy, and there are a couple of key components of the MDS that would really drive numbers upward if one were to decide to do that. Isolation. Coding of isolation is one of those factors that's really important to look at. There's some very specific guidelines on isolation and coding it properly in long-term care. Sometimes MDS coordinators who are nurses by trade can make mistakes in this area, but the requirements are so specific that most isolation or patients that have some type of isolation cannot be coded into the extensive category in this area. So it has to be a highly transmittable active infection that requires a single patient room isolation situation. That patient can't leave the room. They can't leave the room for therapy. They must be in that room through that active isolation the entire time. And many of the patients, quite frankly, don't meet that requirement. So that's one area. That bumps up the case mix score dramatically in a situation like that. So if you've got a building that has 4 or 5 active isolations on a routine basis, that might be an area to look at. Another area on the case mix environment on this MDS tool that really bumps up that case mix number is patients that have COPD. COPD combined with shortness of breath when lying flat pushes the case mix number up very high. I would particularly look at cases where COPD might have been diagnosed while they were an inpatient in the skilled nursing environment and not outside during an acute stay at the hospital, where a diagnosis of COPD honestly might be more accurate. So that's just a couple of the areas I wanted to throw out there with skilled nursing.
So you data analysts in the room, I hope you took some notes there. It makes me want to go home and look at my data, right? So thank you, Dwight. You want to go ahead?
Yeah, sure. So I'm the dentist, and as I talk, I might say things like, I would do this, and just so you know, I wouldn't do it. I'm a rule follower. But these are some things that I could potentially do, and probably the easiest thing that I could do is upcoding as far as dentistry goes. I mean, I'm doing a filling on a tooth anyways, I might as well add a surface on it. It's hard to prove anything with that. I could be doing an extraction, and I might want to make a little extra money from that, so I might make it a more difficult extraction than what it really is. A lot of different levels of extractions. I won't get into it, but I mean, I could certainly say that one is more difficult than it really is. Likewise, cleanings, I think, are a really easy place for this to happen. For instance, you're just getting into doing a prophy. I could easily say that you have deep pockets or something like that because it's a measurement that I make and put into the charts. And I could say you need to come back for a deep cleaning. And it's really not a deep cleaning, it'd just be doing a prophy. Also, I could be doing procedures that aren't really necessary. For instance, that gets into the realm of preventative dentistry, which there's a lot of people saying preventative dentistry is a big thing, especially someone in high risk, but it might not be necessary at all. Like, for instance, if I'm doing a crown on a tooth, it doesn't necessarily need a root canal, but you might add a root canal to it because you're putting a crown on the tooth and it's putting that tooth at risk. A lot of people are sedating patients, I feel, unnecessarily. It's maybe you need to spend a little more time with a person or something like that. And then you can get them to cooperate in office versus sending them to the OR or something like that and getting all the work done in one day. Certainly that could be very profitable, and you can make up some of the money lost that you're not making, especially with Medicaid, but that's one direction you can go. Or you could be charging out for a procedure that you're not doing at all. And on the tooth next door, you could be charging out a filling on that tooth. You're working in the same area, patients don't know, they look at the EOBs and things like that. And they're like, oh, I had some treatment done up there. I guess he did a filling. And so things like that you can kind of get away with. And just routine fees on things like, I don't know, not many states pay for like oral hygiene instruction, or I guess they do, but behavior management and things like that, you can just tack on to a lot of different procedures and make money with that, and it's not necessarily what's going on. And then also things like accepting co-pays and getting visit fees and things like that. When I was a kid, I had Medicaid, and I remember paying money every time that I went into the dental office, and I found out that shouldn't be happening. And so, right, exactly. So things like that. But anyways, it's a struggle sometimes. But all this stuff happens, and it's something that I could do.
Thanks. There may be lots of questions later on dental, I imagine, by some faces in the audience, folks I've been talking to at the conference that are focusing on some dental program integrity, so we may dive further into those later. And we're going to get into how to detect some of the things that Dwight and Rich just mentioned, so we'll talk about that in a minute. Michelle, did you want to add anything?
I work in emergency room, so we don't do our billing. We have somebody doing our billing for us. So I don't have a lot of experience, but I have seen some overbilling, maybe some unnecessary diagnostic tests. But overall, it just would be overbilling for the complaint or the diagnosis.
All right, so medical necessity. What are your thoughts on how we as program integrity professionals can detect or perhaps even prevent the provision of unnecessary services or the billing of unnecessary services? I'm going to call on you, Dwight, on this one.
All right. Well, there's been a lot of focus, obviously, in the last several years on return to hospital in our setting, particularly in the skilled environment. And facilities have upped their game in terms of the number of nurse practitioners, physician extenders that have been involved in those buildings. And I think in a lot of cases that they've been able to detect issues that have come up with patients that have prevented them from going back to the hospital. And sometimes diagnostic tests are in line in order to determine whether or not a patient is declining or if there's a specific need that they need to go to the acute setting for. But when you get over into the area of the long-term patient, a patient's on Medicaid, or they're a private pay, and you've got a situation where a provider or a nurse practitioner is seeing that patient on a 30-day basis in excess of 5, 6, 7, 8, 10 times a month, then that to me raises question. A patient in a long-term environment that's a Medicaid patient should be stable. There shouldn't be the high need to have nurse practitioner or physician involvement 8 to 10 times a month or more. That's one area that I'm always keenly interested in terms of necessity. Obviously, therapy in our realm is a big focus and a target, and we do a lot of discussing with our therapist about making sure that the patient is absolutely benefiting from the therapy session that's being provided, and that the goals that are set are reasonable for that patient. If it's a patient that has prior issues with ADLs, I don't think the goal needs to be that the patient's going to go home and ambulate independently. I think there needs to be realistic goals set, and we monitor those. So from a skilled nursing perspective, those are the areas that I had jotted down.
Okay. So from an emergency room perspective on the medical necessity, an emergency room is used a lot by Medicaid patients just out of convenience, not following up with their primaries. Some of it is they don't want to wait for the appointment. They'll come in. It's not necessarily medically necessary to be seen by an emergency room physician, so it increases the cost. And on some of the cases, because of the HCAPs, we tend to, if the parents are asking for an x-ray, and it's really not evidence-based, we will go ahead and do the x-ray to improve our patient satisfaction. Not necessarily that it's fraudulent, it's just not evidence-based. And so there'll be a lot of extra charges for maybe the complaint. So possibly a way to detect is to come up with the program to have an evidence-based practice line up with the complaint as well as the diagnosis, what procedures and what diagnostic tests should have been done for the complaint and the diagnosis.
And another thing you could do is you can just simply look at the codes. In a geographic area, I assume that the proportion of different codes to each other are going to be similar. So if you have one dentist with codes that are just astronomical in one area versus everyone else, that'd be worth looking into. You might look at individual codes, how they compare. Like, for instance, root canals and crowns. Like I just mentioned, that would be something. You do a crown, maybe do a root canal. Are they similar, or are there more crowns than root canals? That would be more realistic. And so that might be something you could look at as well. And I mean, if you're ever curious, you can always have a doctor look at this. One thing that I would, and you guys do, you have a doctor look at it, but we're all held to the standard of the specialist. A general dentist, it does a root canal, they're held to the standard of an endodontist or an extraction to an oral surgeon or something like that. Have the specialist look at the cases, and I think that would be really where it is. One other thing, and you guys probably already do this, but look online. Because that might tip you off also to see if there's unnecessary treatment happening. I think there's a case on the East Coast several years ago where a young guy, or a dentist anyways, had been doing a lot of extractions on children in the community. And I think that people in the community started talking, and they're like, hey, why is this guy doing all the extractions? I mean, for different reasons. And then it kind of caught up to him in the end, and that kind of is what got the government looking into it.
One thing, just going back, if I may, just a few minutes ago, we were talking about COPD and shortness of breath when lying flat, and I think we did put on our slide, the spirometer is a piece of equipment that is used to detect a patient, or at least provides 3 sets of data that is used in determining if a patient is a COPD patient or not. And I'm just going to state that most long-term care facilities do not have that piece of equipment in the building. Now that's becoming more prominent with facilities now gathering that information, but going back to looking at when COPD is actually diagnosed, if that's during the inpatient environment in that setting, particularly in case mixed states right now, I think that can be looked at just to make sure that that is in fact a proper and ethical diagnosis made based on diagnostic testing.
Thank you so much. There's a lot of really great ideas there. So we heard a little bit of some of our more standard peer-to-peer comparison being referenced here by Rich. So when he's talking about looking at geography, isolating to specialty types, in some senses, I'm sure your programs are all doing some sort of peer-to-peer comparison. But what I thought is especially interesting was his insights on how to structure that peer-to-peer and maybe involving your specialist in structuring that peer-to-peer comparison up front. so that they can guide you under certain areas to look for. And then earlier in his commentary, where we heard about looking at sedations or extractions and areas that are a little more prone to, we'll call it maybe fat finger billing, I don't know, just add a little extra on top. So I think those were all some great ideas for data studies that you can take back. And then, certainly with Dwight, I really like the example that he's providing with the spirometer, and the fact that if it's a piece of equipment that's not necessarily standard, pretty easy to find out if they have that tool to even be making the diagnosis on site at the facility. So lots of really good examples there. And Michelle, I know you mentioned where you talked about, adding treatments for patient satisfaction. I don't know about you guys, but that was a concept I hadn't even thought of. That, that it would be important for a hospital to get, good customer rating. And so, mom really wants the x-ray. There's nothing evidence-based that suggests it. So they provide it. So we may see through some analysis certain diagnostic tests or other things that maybe indicate a trend of medical necessity that's occurring. I know this is a tough area for us as PI professionals, medical necessity, but I thought that was a really interesting concept I hadn't really considered before. So try to sum these things up as we go along. All right, so the next area I want to get into is I was recently reading, and I read a lot with respect to audits that come out, because I think we can all learn from one another, things that GAO is doing or HHSOIG. I'm always looking for new ideas that nobody has all the answers, so we got to keep ourselves in tune. I don't know about you guys, but oftentimes I would read news articles in other states, and then I would go back to my desk and be like, I want to find a doctor here who's doing that same thing. It's a great idea. So I was reading some publications put out by CMS, and they talked about this relationship risk. And we all know this goes on, but my challenge that I would always think is, well, how do we find that in the data? How do I find the docs that have succumbed to this, solicitation for maybe kickbacks or trading of beneficiary names or lists? Unfortunately, we have inside-outside schemes that are of a concern. So again, I thought I'm going to turn to the panelists and see what they think about this. So CMS says that physicians encounter 3 types of business relationships that might raise fraud and abuse concerns. They say relationships with payers, relationships with fellow physicians and other providers, and relationships with vendors. So how have you guys, if you have observed this in your particular careers, what are some things we could look for to help point to maybe a relationship that's crossed the line?
Go ahead.
Okay. I have come across this. I worked with a physician that was dating one of the reps for a certain medication, Toradol. I'll just put it out there. So it's Ketorolac or Toradol. It's an anti-inflammatory. It can be used for, it's a pain and analgesic. It's equivalent to ibuprofen. So we all kind of know what Motrin is. And you can actually give Motrin instead of the Toradol, but he gave Toradol to a lot of the patients. They were getting IM Toradol where they probably could have just gotten Motrin, but he was trying to increase her sales because she was the vendor. So yes, it wasn't necessarily, I wouldn't say fraud, but definitely unethical. It's not necessary. But it wasn't that he made it up. It was more of, let's just, they'll get better with the Toradol as well as with the Motrin. And what else? I had one other one of, hold on one
Dinners.
second. Oh, yeah,
dinners.
The dinner. Well, the referral to one physician. So if we have 3 physicians, say 3 pediatric cardiologists on the panel, and you'll find, if you, not necessarily in the emergency room as much because we have an on-call list, but when you're working with primary, you'll have one primary that only refers to the one nephrologist or the one cardiologist when there's several other physicians on the Medicaid panel, but there's only one referral from that primary. I would think that would be a red flag that there might be a relationship there.
One area that I wanted to point out in this is, in terms of physician relations, whenever I'm looking for a medical director, I try to vet out, really, really good, what relationships they have, if they do have any, or any ownership in any, common interest businesses like X-ray or lab. Anytime a physician can write an order that results in a diagnostic test or a service that could be connected to the building, I'm really looking out for that. So, typically in a nursing facility that's an average size of 120 beds, your average X-ray cost per month shouldn't exceed normally on a routine basis, $5,000 a month. I mean, if you've got a building that's experiencing $7,000, $8,000, $9,000, $10,000 a month in X-ray, or if they're experiencing $6,000 or $7,000 a month in lab, that's an area that I would look at pretty closely, because typically $2,500 a month on X-ray, approximately $1,000 on lab a month, maybe $1,200. That's usually a normal, fair average for a healthy, skilled census and long-term care population. So any equations that connect the dots to those areas exceeding those numbers, certainly could be looked at.
I agree. I mean, these professional relationships really come into play. And I knew an orthodontist whose wife owned a radiology center. And obviously, if he ever needed some x-rays, and he'd need them quite often, he'd refer to this center. Now, since then, I think they got, called out on being unethical, and that they sold the radiology practice. But still, things like that exist. And if it is all in the same building, that's hard. I mean, especially in dentistry, because a lot of things are happening in the same building now for convenience. You were seeing a dentist, but now you can go to the dentist in the same office. You can see an oral surgeon or an endodontist, or even a prosthodontist. And so is that questionable? It's hard. So I think looking at irregularly high referrals would be something that you could look at for that, like Dwight was saying. Also deals with facilities, like for instance, a home or a school or something like that, dental facilities at that location, where the school themselves might get something in return for bringing down patients so that you can see them. That might be something worth looking into also.
Great. Lots of good ideas. Closely related, before we move off this topic, is kickbacks. So I often wished we had access to just bank records whenever we wanted them for our analytic purposes, but I don't see where that's going to happen anytime soon. So, and frankly, if they're smart enough to use cash, which they not all are, I love the checks to each other. They're just liquid gold, but they could use cash. So I always struggled with kickbacks. Unless you have someone on the inside who's relating the scheme to you, providing witness testimony where you can use data to support the validity of what they're saying, how could we detect kickbacks a little bit? So as the group was talking and we were preparing for today and thinking through some of these challenges, I thought about kickback schemes. And, is there anything we can do to really detect them? Dwight, I know you talked about in specific this frequency of patient visits per month, and you just briefly mentioned that earlier, but if you wanted to dive into that a little bit, and then we'll hear some insights from the others. Right.
Well, it's a relationship where the medical director is allowed to bring his NP group in, and they in turn round robin, generating visits in excess, or can be in excess, that's either ignored, not monitored, not watched, and that costs the program money. There was another example many years ago. I had a mobile dental unit that approached me with an elaborate, what I called a scheme. It was an insurance scheme where every patient in the building was going to be required to be on the insurance. They would pay in a monthly premium, and then this insurance company would be, or the dental group rather, would be in control of choosing which patients to see, what procedures needed to be performed, and then they would bill that insurance. But everybody was going to pay into this. And I think on some term, I think the state had allowed this to happen in terms of patients being covered, but I think the insurance company figured out a way to really kind of try to maximize on it. So, one thing I'd like to mention in terms of dental, if I were looking to protect money in a program, particularly in TennCare or Medicare, is I would have an additional step for the dental group to provide the provider with an authorization form that says, we're going to provide this root canal on this patient. And we want to make sure that we have we have an authorization to follow through. Of course, patients and families already consent to treatment, but sometimes dental groups go in and they'll actually perform the service, and then you won't know it happened till it's over. So, some of those visits, I think, could be prevented if the provider themselves, if the dental group was mandated to provide an additional level of authorization before that procedure went into play, so that we could make sure the program money is not irresponsibly spent. A root canal on a patient that's 82 years old, that's not experiencing pain, that has their teeth cleaned once every 6 months. I think we need to sit back and we need to talk about what is the real benefit of that patient receiving that service before it's actually gone through with.
So but as far as the kickback schemes and how to detect them, I would just go on from the last one, what I had said earlier. It's just overprescribing on one medication. If you find a physician that just prescribes one medication and consistently throughout the practice and only sending to one physician referral, and when there are plenty to go to, when there's more than one, I should say, not plenty, but if there's more than one on the list and there's only one referral being given.
And another situation that I kind of ran into, and it was probably just a guy just talking, he said, wouldn't it be great if because he had a piece of property, he's a pediatric dentist, and I'm practicing on the property, wouldn't it be great if I rented to an orthodontist? And now, this may not be in Medicaid, but I mean and then basically an agreement between the two is he would get his referrals and charge a little extra on rent. Well, and so the pediatric dentist would end up getting a little extra money on rent in order to get these referrals. And so, I mean, it can be pretty sneaky, and I don't think this actually came through. I mean, it's unethical, but but you know what I mean. I mean, if this didn't happen, somewhere it probably did. People are thinking about it.
That'll segue into our next question nicely. Rich, if you don't mind going first, and talking about others that you may know of who've experienced pressure or incentives to improperly bill or to commit program fraud. I know we talked about the recent scenario in California with Cool Smiles, if you want to talk about that.
Oh, yeah. Well, I mean, there's a lot of incentive. I mean, we all know graduates have this insane amount of debt. The Wall Street Journal actually published an article in which there was an orthodontist who graduated with $1 million in debt. And it's ridiculous. I mean, so if you're talking about incentive, there's a lot of pressure for these people to be able to make money and be able to still make a living for themselves and stay afloat. But that's a financial incentive. But then there's also incentive as far as big businesses that have different values. Maybe you have a set amount of money that you make every day, but then on production you make a little bit extra if you make a certain production. So there's a lot of push to do more procedures on these patients. And then also at the same time, some companies I've even heard of having quotas. You need to do this much of certain things. There's like a fitness place where you have different things on the wall saying, I did this amount of work. And so there's competition between doctors within the facility. And I think if you look up Cool Smiles, was one of them recently made the news, where a lot of things like this were going on. And that's another thing. Corporate dentistry is where there's a lot of opportunity for this thing to happen. And corporate dentistry is something that's been coming up over the last several years, and right now it's all over the place.
Two things I want to mention in feedback before we hear from the other panelists on this one. So one item is in respect to this concept of need, right? So you have young graduates with a lot of debt, and it creates this pressure to pay the bills. We're probably all fairly familiar with the fraud triangle, and that's one leg of the stool. So identifying perhaps through some non-traditional data sources, not just what your providers are reporting when they enroll in the program, but taking a look at them. Do they have bankruptcies, liens, and judgments? What does the health of their business operation look like? Is their business paying its bills on time? And if it is a young practitioner, you have to factor in they're probably dealing with a lot of personal debt on top of whatever else might be happening financially for them that's available within the public record footprint for both them as an individual and as a business entity. So that's one area where you might be able to think a little outside the box, maybe use some of those non-traditional data sources to identify some of your more at-risk providers given that component of need. So just wanted to mention that one. Did you guys want to add, Dwight?
Yeah, it's just, I don't have a lot to add on this one because in working with the hospital, we don't do our own billing, and you're employed by the physician group or the hospital. So I just want to put the 2 cents in there.
I can add one more thing. There are multiple companies out there right now that are providing nurse practitioners to long-term care buildings, and typically they offer those nurse practitioners at no charge. But I can assure you the pressure is on the nurse practitioner to hit a certain number of visits per day in order to cover their cost. And if you can imagine having a job and every day you go to work, you've got to make sure that you get X number of visits per day in that building to keep your job, because if you can't meet those numbers, then you're not going to have a job. That's a lot of unfortunate and unnecessary pressure that does lead to potentially some bad decisions made on the part of the nurse practitioner.
All right, we're going to move on really quickly here. Just touch on one item. So I talked with the panelists a lot before the session today about opioids, but I'm pretty sure you guys are getting a healthy dose of opioid-related sessions, so we're not going to dive too deep. Although I think Rich had an interesting experience with another professional he's aware of that I thought was relevant to mention. It's a little bit of a different spin on things. It's interesting what will happen as now it seems the national conversation about opioids has emerged. Y'all know this has been happening a long time. But as that conversation emerges and there's now this hesitancy to prescribe opioids because of the intense eyeballs on the situation, people don't just get better and addiction doesn't go away. So where are they going next? And so for me, opioids is about playing chess. We obviously still have to deal with the move we have to make today, but we need to be thinking about our next 3 moves because they're going other places. If you're not looking at fentanyl patterns, you need to be. So talk with your local narcotics officers. They will tell you where the drug seekers are going. They were the best source of intelligence for me at Florida Mafuku, was sitting down with local drug task forces. So just an idea there. But I think Rich is going to share a cool story about that. And then I think each of the panelists essentially told me in summary that right now everybody's kind of panicked about opioids. So prescribers are staying away from them whenever they can.
Totally, it's a good thing. And I mean, it makes people do funny things. It's unreasonable. The story that I'm thinking of is a dentist in Southern California who recently graduated, and he had a girlfriend who he was prescribing drugs for. And apparently he started joining in and he started prescribing it for himself. Obviously that was discovered and he lost his dental license, so he decided to supplement his income by robbing banks. And so, yeah, exactly. And so what a slippery slope that is, right? And so...
Addiction is real,
yeah,
friends, it's real.
Exactly. I know, and I think he ended up getting a total of maybe $15,000, I think, something like that. And man, what a change in careers and what he could have been. Yeah.
A little bit of a different take on what you're hearing in your other opioid sessions. So, all right, so we'll move on from that and move into government payer risk. So just one area I wanted to touch on with the panelists is, again, based on their vantage point, is there any patterns that you could think of that we could specifically look for as we're analyzing data, not only about our providers and our beneficiaries, but also claims? Just looking through the data to identify some patterns specific to Medicaid or Medicare type programs. Dwight, I think you had one there, and also Michelle, you had some good thoughts about looking at claims patterns and bell curves.
Well, it kind of goes back up the opiate. It goes back, into pain medication, and certainly I have seen a spike or an increase in the number of patients asking for pain medication. And I'll just say that the way the system is designed, the regulation, and what we have to follow. We all want to make sure that we keep patients out of pain. I don't think anyone can argue that we don't want a patient in one of our skilled nursing facilities to be there in pain. But I think that, and I've listened to nurses, talk to patients about, what is your pain right now on a scale from 1 to 10? And they can sit there just as you are sitting there in your chair right now. And I've heard them say it's an 8.5. When a patient indicates that, as a provider, there's a lot of pressure on us to make sure that we keep patients out of pain. And I know we can't fix that in this room here today, but if there were a way to give the providers more leverage in terms of really making sure that a patient's pain level, requires a narcotic, something that can be treated with Tylenol, if the provider and the medical professionals in the building had more discretion in determining if narcotics needed to be used, I know that would certainly help that case. Because I think it is a real issue, and I have seen a spike in the last 3 years in particular with patients wanting pain medication to an extent I've never seen before, and actually leaving AMA if they can't get it, which is just pointing to an addiction problem.
And Dwight, I wanted to specifically ask you about a scenario we discussed about procedure codes and charges from the ancillary providers with patients on hospice care. We talked about that sort of scenario with significant Part B billing.
Yeah, just making sure, patients that are on hospice obviously are at end of life, and typically you're not going to see or shouldn't see a lot of therapy provision. You might see some speech pathology provision for some swallowing safety issues, or you may have some upper body strengthening just for bed mobility and positioning. But by and large, obviously hospice patients, you should not be seeing quantities of therapy, particularly in case mix. You shouldn't be seeing case mix patients on hospice that have therapy that's doing nothing but pushing the case mix number up. And unfortunately, or for the facility, it's a positive because it is more revenue, but you really shouldn't see that with hospice patients.
You had one?
Oh, for patterns? Yes, so in the emergency room, we see anything from minor injuries to life-threatening. And generally, it follows a bell curve. So we have a few that come in for minor injuries that are billed at a 5, and then the others that are coming in emergency and near drownings that would be billed at the 1 that's critical care. So you would generally see a bell curve. So the pattern to watch for is the bell curve. If you're seeing anything skewed to the right, when we're not going to see only severely ill patients, that should be a red flag.
Rich, do you want to add anything on this one, or do you want to move on to the last section? Good?
Keep on moving, yeah.
Okay. All right, so the last topic area we're going to cover just a little bit is some thoughts from the panel on what we can do, ways in which maybe we can think about our enforcement efforts, our deterrent efforts. Do these things work? Does education work? Policy changes? Do they know what we're auditing for? Are they actually paying attention to that and modifying their behavior? I've had some cases in my career where that's been the case. I had a physician, a federal case that I worked on, tell us in a proffer he had been list billing for 15 years, and he'd been list billing the exact opposite of what he knew the state was doing. He said, I know that you guys are paying attention to overutilization of 99215, so I never bill that code. I only bill 99212. Duh, right? As soon as he said it, I thought, man, it's brilliant, but yet not. So, I wonder, do they really pay attention to what we're focusing on? I think in some areas you can't help but pay attention. See earlier statement on opioids. But in other ways, I wonder, do they know? So I asked these guys, what do you think we can do? What helps? What makes a difference? And they had some creative ideas. Maybe you guys could just touch each a little bit on what you thought about provider education.
Yeah, provider education is very important, and not only provider education, but also staff. If everyone, and I mean most of the staffs in a dental office anyway, do have some sort of license that they need to keep up, so you're talking about CE anyways. And the more people that know about the rules, the more, I think, the more checks and balances within an office. So I really do think that makes a big difference. Now, I don't think we need to learn anything specific about Medicaid in our license renewal, but that would be wonderful if it was part of it. We all need to do some sort of law renewal every couple of years, so that'd be great. More people who know about it, more people are checking and balancing, more accountability also. I mean, if you have a lot of things come up by whistleblowers, by people who, leave the office and say, heck, this guy is doing something fraudulent. And so it would be beneficial for everyone to be part of that. And it'd be nice, I don't know, it'd be okay for it to be a core requirement. I see it as being a little bit difficult at the same time about getting physicians and staff to do this, because it's just one more thing they have to do. And sometimes the whole process can be very frustrating in and of itself, but I think it would help.
I agree. When I was discussing with other physicians about this, do you think that education really works for fraud, deterrent, and also waste? And they all agreed, most of the providers that I spoke to, and felt maybe during, just like we have domestic violence every 2 years, and to keep our license up, just to include that in part of it. And I know you had mentioned the law, and so we could, I don't know if they can put it in with
right, along with law and
with
ethics,
the
have something in there.
requirements,
Yeah.
right? So I mean, it's not hard. They're normally programs that we do online. So you do a quick domestic violence. We do it every 2 years for our license renewal. If you're a Medicaid provider, then it should be mandatory to have a small program that says this is what fraud is, this is what waste is, and also, I don't know if you could go to the patient side, also to have them more aware of what fraud and waste is. It might help with decreasing payments.
So how many of the states require continuing education training for Medicaid providers on what fraud, waste, and abuse is? Yeah, thought that was a pretty good idea. Maybe a bit of a legislative lift, but when you talk about cost-benefit analysis, can't imagine it would be that expensive for a few slides in an online training program. Who knows? Take that one home. If anybody has any success, email me. I'd love to know about it. Right?
Well, I think obviously education is great, and really what I would like to see is education in terms of case study or examples. A lot of times providers are out there trying to operate, and a case study or an example of a fraudulent, or maybe it's just error on the part of the provider that it is creating the waste or the abuse of the monies in the system. If we could study some of those case examples to ensure that it's not happening in our environment. Again, a couple of nationally publicized cases of therapy being pushed in Medicare Part A patients obviously causes us all to take notice and to re-examine our internal controls and talk to our staff about, look, make sure that the minutes you are providing are ethical and for that patient. It's all a very good redirection. But obviously, for any company, this type of thing starts at the top. My company, very fortunately, CareRight, right away when I said I had the opportunity to come down here and speak, without hesitation, ownership said, absolutely, yes, we want you there. So I know that it starts at the top, and it has to filter all the way down through the building, all the way down to the CNA working on the floor.
For those of you looking at your contracts with your managed care providers, maybe throw a provision in there as they're doing their regular required continuing education. They also have to offer the state's 5-slide package on fraud, waste, and abuse. Worth a try, right? And then one last point I want to make really briefly. We have another question that we're not going to get to because I do want to make sure we leave the remaining minutes for some questions from you guys. But in looking at other deterrents or things that are out there, one interesting observation I heard in talking with our panelists was this concept of whether or not there's a difference they notice between government payers and private payers and there being a deterrent for committing fraud. And they said, absolutely, with the private payers. Why? Not only are the payers themselves more often scrutinizing, but so are the patients. So in our government program, I'd love to get more Medicaid recipients responding to those EOMBs, but we don't really see high returns on those. We don't see as much scrutiny, just I think by human nature. looking at bills and making sure every charge and every service was actually provided if they even have exposure to it. So we lose that benefit. How many of you guys check your credit card statement, your insurance bills, everything you are physically writing a check out to make sure the charges are correct? Most of us do. We look at that stuff. So we lose that opportunity. And on the private side, they tended to feel that the private payers are auditing and scrutinizing payments a lot closer, probably because there's more of them. But we'll leave that there. So just another thought that this is kind of an area of vulnerability for us in Medicaid, and maybe some creative ways that we can work to campaign to get information from our recipients themselves, and also from staff that work in the facilities. So whistleblower cases are often some of the best cases that we make, right? But how do you get that information? Rich said, do you read online reviews? Because people put stuff on the internet. And I was like, yes, we do. But if you're not doing that in your state, check Yelp, Glassdoor, even employment sites. People will tear up their former employer online. And sometimes, like, he made me bill for a bunch of stuff that was wrong. Huh? Well, that's a case I'm going to look at, right? So take a look at some little non-traditional ways, perhaps, that you can explore to identify your whistleblowers. But we're going to move into audience questions. And I do have a microphone that I'm going to walk to the questioner, because that will help us for the recording of the session to be able to hear the question. So don't all fight me for who gets to go first.
I'm wondering if you have any thoughts. I did a PI project in a Midwestern state that was having real issues in non-emergency transportation. And what we found was that it was not individual companies, it was an organized criminal enterprise that had purchased transportation providers, they brought in doctors, and had a population that had all three kind of stools, legs of the stool, and were generating claims that way. Do you have any thoughts about kind of individual provider fraud versus more organized and criminal enterprise fraud?
Miami? Okay.
I know,
I'm just calling you out.
Which is funny because I was just telling Rich earlier, when I'm driving to work at a very ethical hospital, obviously I wouldn't be working there, but I go by these smaller, kind of what you're talking about. There's one, I'll just say CAC, and you see a van that picks up patients, and they're bringing them in, and you can see them being dropped off. There's also another hospital that I kind of question, how is that an emergency room? Because I know that's more of a clinic, but it does say emergency out there. So I don't really know how they're doing it. There is definitely some question. I don't know about the investigation side. So I don't have a lot to offer, but I do see it. Being from Miami, I think there's a lot of scams. There's not a lot of rules in Miami. They're just suggestions. So that's what we call them. And that red light, that's a suggestion. The stop sign, a suggestion. I mean, and then that is actually the culture there. So it runs into medicine and healthcare.
Yeah, absolutely. And I can just tell you from my experience in Pondera and talking with different folks and clients around the country, we're still seeing both, right? There's still the same old schemes and scams that we've dealt with kind of forever, but there is more of an emerging. It is more common for us to interact with those types of groups in working with our clients. They're seeing more of these folks who are actually endeavoring into the business from the start to commit fraud, and they're very, very good. The penalties, as you know, often, I'll just say never, include minimum mandatory sentences. They're often not prosecuted if you know that story, right? So it's highly attractive. We had an investigator from Miami last year on our panel who talked a lot about criminal street gangs who are moving from trafficking drugs to healthcare fraud.
I would like a list of all your providers that you drive by every day. This, I guess, isn't more of a question, but maybe more of a comment. There was a book that my friend told me about. He works for the U.S. Attorney's Office in Kentucky called American Pain, and it's apparently about the first big fraud scheme in Florida, about how this, like, basically mafia-type place went through and they started up the pain clinics and all the x-rays and everything. It'd be a real good way to find some insight on how people are thinking about committing the fraud. So, just a comment.
Yeah.
American Pain, if you guys didn't write that down, is the name of the book, American Pain. Questions?
Long-term care and podiatry. What am I looking for? You get a lot of services. If we're paying them a per diem for all of that inclusive care, why would podiatry be carved out of that?
Well, when I think of podiatry, I think about services like that. I'm really specific to looking for diagnosis. Typically, a diabetic is somebody that I would want a podiatrist to see. If you have a person who's not a diabetic, for instance, that had a high frequency of visits or a lot of things going on, that might be a red flag, because typically a building can handle a lot of the issues with the individual's feet outside of the podiatrist, unless something specific comes up that need to be seen. So I think I'd look at the diagnosis and the relevance of that in terms of podiatry.
Just another comment on the MDS. What's unique to Medicaid versus private pay rate is the family realizes when the rates go up, but Medicaid doesn't, because we're just paying the claims, so no one's advocating for these higher levels than where they need to be. So even checking to see if someone stays at maybe they had an incident with bed sores or something like that, and they're at a higher classification, do they ever drop down? And I'm just saying that's one of the things that we're interested in, because like I said, the private pay, because we take their appeals as well. I mean, they're in the office the next month saying, why is her rate so much higher, based on some of this stuff. But when no one's out there advocating for the Medicaid recipient, that could happen all the time and we'd be none the wiser.
Right, okay. Well, in terms of the MDS tool, you can have what's called a significant change assessment. That can be for a decline or an improvement. Typically, if a patient has a couple of variables that can generate that assessment, it will make that clinical rug go up or down. I would say the healing of a significant wound would be considered in many cases, would call for a significant change assessment that would in turn lower the rug score, lower that case mix score, because fewer services are being provided at that point. So I guess the answer to your question is yes, that tool can go up or down. Typically an MDS is performed on a long-term care patient once every 90 days. That's just sort of the typical, but you can have those other variables in between as well. Does that answer your question? Okay, thank you.
I didn't hear it mentioned, but maybe you did. FQACs to me are just legal stealing mills because of the high encounter rate that are paid and the unbundling, if you will, of service lines, especially in dentistry, where you can have the same services over 4 different visits that a standalone brick and mortar dentist gets, one visit time in with a hygienist and an oral exam, and in an FQAC they can be paid hundreds of dollars per visit over 3 weeks. So I don't know how we address that, but every state that I've ever talked to, whenever you mention FQACs, they just roll their eyes. And I think it's just, the system is just set up. I understand why they're doing it, but I don't think we've thought it through at the state level. They seem to be very highly sought after. They have a lot of political cover. So I think it's an area that we need to look at, because the churning or unbundling of service lines inside FQACs can quadruple, if not 10-time-fold, the normal cost of a brick and mortar service provider.
So honestly, I don't know enough about that to really make a comment, but I mean, certainly if it's worth looking into, I mean, to look at all the billing processes and everything else. But I don't know enough about those systems to really give you a recommendation one direction or the other.
Okay, for the dentist, you talked about corporate dentistry. Do you have any experience with DSOs? And if you do you see anything there where we might be looking for fraud, waste, and abuse within how they influence the work?
So the organization,
This is a safe space, Rich. You can,
Yeah.
you can share.
So honestly, I don't know where to start. I mean, I know where I've been. It's hard. I don't know. With these organizations, I do know that there's different structures in them to maximize profits and to encourage doctors to maximize those profits, and assistants also. It's just like anything else. I mean, to determine what's medically necessary, you just look at those systems. And I mean, a review happens to all of us. We expect it. And so that would be something where you can go in and evaluate that, I imagine.
So you're still evaluating the individual dentist and then seeing if there's a tie to that behavior to the DSO potentially? Is that what I hear you
I
recommending?
think so. I mean, I don't see any other way around it to discover fraud. Any ideas? Sorry.
Other questions? Okay. All right, well, with that, I think we'll wrap the session up. I think we'll be here in this room for just a few minutes. If you had any questions you didn't want to ask in the big group, thank you very much for participating in the session.